As we have already discussed, hyperparathyroidism is one of the commonest causes of hypercalcemia and also is the most easily remediable cause, which has got a benign course and good prognosis. So, increased screening for serum calcium and wider availability of IPTH, that is intact PTH assay, are some of the important reasons for increased recognition of this condition, hyperparathyroidism. 80% of the cases of hyperparathyroidism are due to single adenoma of the parathyroid glands. We know there are 4 parathyroid glands, usually one of them shows up the adenoma, and 80% of the cases are due to a single parathyroid benign adenoma. Usually it is an adenoma, or sometimes it could be due to hyperplasia of the parathyroid gland. Rarely it could be due to parathyroid cancer. High parathyroid hormone in the setting of hypercalcemia is directly indicative of hyperparathyroidism. Normally when there is hypercalcemia, we expect the parathyroid to be suppressed by feedback inhibition. But if hyperparathyroidism and hypercalcemia are going together, it means it is primary hyperparathyroidism causing hypercalcemia. It is a slowly progressive disease, and if we do a Sestamibi nuclear scan, we can pick up which particular parathyroid gland is showing the adenomatous changes, and ablative surgery can be used without much of difficulty. 25% of the cases of hyperparathyroidism with adenomas, they require surgery. Remember, recurrent laryngeal nerve paralysis is one of the known complications of parathyroid surgery. This is a nuclear scan imaging of the parathyroid glands using Sestamibi. When we give Sestamibi and then do a nuclear scan, Sestamibi is a tracer nucleotide, and when you give it and then try to scan the parathyroid and thyroid region, we can find out which particular part of the parathyroid gland is affected. You can see here the 2 salivary glands there, the submandibular salivary glands picked up there in the Sestamibi scan, along with the 2 lobes of the thyroid gland, of course, the right and left lobes, and we have got a much larger than the thyroid, a parathyroid adenoma, which is supposed to be, parathyroid gland is supposed to be a very small tiny gland compared to the thyroid gland on the back of the thyroid gland. And we see here the left inferior parathyroid gland is the one which is enlarged in the 65-year-old male who had presented with a hyperparathyroid storm with a serum calcium level of 16.4 milligrams %. So, this is the case of hyperparathyroidism, and this gentleman underwent an ablative surgery, and the calcium levels have dropped down to normal level, and the prognosis was excellent, and he was totally cured of the condition. There are certain criteria laid for choice of a patient for surgery of the parathyroid gland. Serum calcium level must be at least 12 milligrams or more at any time on 2 or 3 repeated examinations. Episodes of hyperparathyroid crisis also indicate surgery. Marked hypercalciuria should be seen with a urinary calcium of more than 400 milligrams in 24 hours. Nephrolithiasis or impaired renal function bordering on to chronic kidney disease can be one of the indications. Osteitis fibrosa cystica, which is a thinning of the cortical part of the bone due to bone depletion and intense osteoclastic activity under the influence of high parathyroid levels. Reduced bone density, as can be seen by the DEXA scan, Z score less than 2 is also an indication for surgery. Classic neuromuscular symptoms with proximal muscle weakness and atrophy of the muscles, hyperreflexia and ataxic gait are also indications for surgery. Any patient younger than 50 years is also a candidate for parathyroid surgery if we see hyperparathyroidism in the presence of hypercalcemia. In this slide, we see vitamin D related hypercalcemia. 25 hydroxy derivative of vitamin D2 is the usual supplement available in the medicines that people take as supplemental vitamin D. the level of 25 hydroxy vitamin D3 is to be measured if you want to know whether it is really vitamin D toxicity. In certain granulomas like tuberculosis, berylliosis, sarcoidosis, leprosy, and in these conditions the macrophages are there, and these macrophages, and in lymphomas, particularly Hodgkin's lymphoma, these macrophages in these conditions, they cause extrarenal conversion of 25 hydroxylated derivative of vitamin D3 into 125 dihydroxy derivative. Normally this 125 hydroxylation, that is the first position hydroxylation, occurs in the kidney, but these macrophages take the role of the kidney and put a forgery signature on the vitamin D check and make it a 125 dihydroxy derivative, and which is nothing but the active calcitriol, which absorbs more and more calcium and phosphate from the gut and relates to the hypercalcemia of vitamin D toxicity. It is obvious that increased levels of calcium in the blood suppress the parathyroid, and the parathyroid levels will be markedly low if we do an IPTH test. Calcitriol levels or vitamin D levels, if we measure in the serum, they will be very high. Of course, the treatment will be stopping the offending use of vitamin D either in the supplemental form or in the dietary form or the injectable form. And remember, hypervitaminosis D with hypercalcemia is a very easily treatable condition of hypercalcemia. All it requires is stop the offending drug and give him or her glucocorticoids every 6th hourly 1 cc of betamethasone intramuscular over a period of 1 month or more. Slowly we have to reduce the steroid dose after a period of 1 month, of course carefully monitoring the serum calcium levels. So the dose required would be 1 cc or 1 ml of betamethasone every 6th hourly, IM or IV does not matter, and it has to be given over a period of 1 month or more. Of course, look for hyperglycemia and other associated problems with chronic steroid replacement, but nonetheless the hypercalcemia here is more dangerous and it should be corrected. Of course, steroids need not be given lifelong. The role will be only around 4 to 6 weeks. After that we can taper the steroid down. Initially we have to manage hypercalcemia vigorously with the treatments that we are going to discuss in our subsequent slides. We have seen the hypercalcemia due to hyperparathyroidism and the hypercalcemia due to vitamin D toxicity. Now in this slide we see the hypercalcemia of malignancy. As we have already discussed, the hypercalcemia of malignancy is mostly mediated by systemic parathyroid hormone related peptide, also called the PTHRP. It is also called humoral hypercalcemia of malignancy. PTHRP mimics the bone and renal effects of PTH and is not suppressed by the calcium. Normal calcitriol and suppressed levels of PTH can be seen in the blood. Excessive bone lysis due to primary or secondary bone deposits can cause hypercalcemia without there being a PTHRP raise. Multiple myeloma and metastatic breast cancer present in this way with excessive bone lysis, either due to the primary involvement of the bone by multiple myeloma or due to secondary deposits of breast cancer producing osteoclastic activity and bone lysis. In osteolytic hypercalcemia, remember, the alkaline phosphatase released from the bone in the serum will be very much markedly elevated. So measurement of SAP is a secondary evidence that there is excessive osteolytic activity occurring in the bone and causing hypercalcemia. Hodgkin's lymphoma also, there is an increased production of calcitriol. In Hodgkin's lymphoma, what happens is the macrophages of the Hodgkin's lymphoma convert the 25 hydroxy derivative of vitamin D3 into 125 hydroxy derivative or the active form of calcitriol, and this active calcitriol or vitamin D3 increases calcium absorption in the gut and thus produces hypercalcemia. So this is in nutshell about the hypercalcemia induced by different malignancies. In this slide we look at some of the medications that cause hypercalcemia. The commonest offending drugs are the thiazide which are very commonly used for various conditions, and these increase the calcium resorption in the renal tubule and cause mild hypercalcemia. Remember here, thiazide hypercalcemia is never moderate or severe. It is mild hypercalcemia from 10.5 to around 12 milligrams or lower than that. The beauty of this particular condition is it resolves after discontinuing the drug, and thiazides, remember, sometimes unmask the underlying hyperparathyroidism. Already there may be underlying hyperparathyroidism producing some hypercalcemia, and if that person is given thiazides due to some other reason for some other medical condition, naturally the hyperparathyroidism will be unmasked and severe hypercalcemia may be precipitated. Of course, the other drug induced hypercalcemia will be milk alkali syndrome, where persons used to consume lot of milk along with alkaline antacids, calcium carbonate containing antacids. So the calcium is absorbed and the milk in the calcium also is absorbed, and the alkalis favor the environment for calcium absorption. That is what is called the milk alkali syndrome. It is not commonly seen nowadays because the H2 blockers and PPIs have taken over the antacids in the treatment of peptic ulcer disease. Lithium salts, when used in depression, they do cause hypercalcemia because lithium increases the set point for the PTH suppression. Normally, if the calcium levels raised to around 10.5 or 10.7 or 10.8, the PTH levels start getting suppressed. But lithium raises the set point for the PTH to be suppressed. So much so, even in spite of there being significant hypercalcemia, PTH continues to be secreted, and that extra PTH produces hypercalcemia. Excessive vitamin A is also known to produce hypercalcemia by increasing the bone resorption and thus causing hypercalcemia. Here we see in this slide some other miscellaneous causes of hypercalcemia. The one condition which is genetic one is the FHH or familial hypocalciuric hypercalcemia. It is an autosomal dominant disease with 100% penetrance, and all the siblings of the affected persons will get the disease. It is a calcium receptor gene mutation. Moderate hypercalcemia with normal and increased levels of PTH are seen. The key to the diagnosis is 24-hour urinary calcium. Normally, in the face of hypercalcemia, we expect urinary calcium to be much higher, but in this condition, because it is a hypocalciuric hypercalcemia, there is an excretion problem of calcium at the kidney. We see urinary calcium will be very low. Such people, they are not, due to hyperparathyroidism, they will not be benefited by parathyroidectomy. Of course, other causes like high turnover of bone in conditions like Paget's disease or prolonged immobilization can also produce hypercalcemia of mild to moderate degree. Rhabdomyolysis. In rhabdomyolysis, what happens is the muscles are lysed, and in their place calcium is deposited. In the recovery phase of rhabdomyolysis, the calcium is again withdrawn from the muscles, and that calcium extra load is presented onto the kidney. Kidney will not be able to handle all that calcium. There will be hypercalcemia associated with nephropathy in the recovery phase of rhabdomyolysis. These are some of the causes of hypercalcemia. With this, the discussion on hypercalcemia and its causes and the mechanisms of calcium metabolism and calcium homeostasis, the hormonal control, everything has been covered. And now we have the last session of this particular CME, which will be the treatment of hypercalcemia, which we will be seeing in the next subsequent slides.